Okay, ready.
So Dr. Margetis is the site chief at Mount Sinai Morningside, and he's the director of spine at Mount Sinai Union Square. He trained in Greece and then came to Cornell, where I was a junior resident at the time, and completed a pediatric fellowship and subsequently went to the Cleveland Clinic to complete a spinal deformity fellowship. He brings a great deal of complex spine expertise to the department, and I can speak for myself in saying that he has supported a number of my decisions on the management of spine-related issues in pediatric patients, and as well as being widely published and an active member of our department. He also has a wife and a young family that he spends his time with. He'll be presenting to us today on the Mount Sinai Morningside spine experience, I believe.
Trauma experience.
Trauma experience. My apologies.
Thank you, Peter. Can you see my screen?
Yes, we see. Yes, we can.
Okay, very good. So good morning, everybody. Today we will discuss about the experience from Morningside about the neurotrauma that we treat over there. Mount Sinai Morningside is our department's trauma center in Manhattan. We also have Elmhurst located in Queens, and we are all familiar with the great job that is being done over there. So let's start and with some slides and let's see whether neurotrauma or trauma in general is an important problem, whether we should care about that. So these are some data from the CDC, and we can see that across all ages, unintentional injury is the third leading cause for years of potential life lost. And when we check younger ages below 65, that actually becomes the first cause for years of potential life lost. So it has a significant impact on our society. And some additional statistics also point to the same direction. And we can see that especially in younger ages, unintentional injury is the first cause of deaths. And even in older ages, it still remains like an important cause. And in terms of the mortality, there are approximately 60 deaths from unintentional injury per 100,000 population. In terms of neurotrauma specifically, the most widely cited statistics come again from the CDC, and there are more than 2 million people that they visit the emergency department every year for TBI. 300,000 of them, they get hospitalized, and unfortunately, approximately 50,000 people die from TBI every year. And in addition to the incidence of neurotrauma, we have somewhere between 3 to 5 million people who survived the TBI, but they're living with disability caused by the traumatic brain injury. And of course, it's not just a national problem, it's a global problem. So there are multiple classifications of a traumatic brain injury because, although we like to group these patients together, but in reality, there are many different pathologies that they're being classified as a traumatic brain injury. This is a very good example where all these 6 patients, they were in coma, they had disease less than 8, and they were classified as severe TBI. But as we can see, they have totally different pathologies. This patient had the epidural hematoma, this patient had contusions, DAI, SDH. So pathologies that are very different to treat and with totally different prognosis. So common classification is to classify the TBI according to these 6 types of brain injury. I will start with some slides for the more junior members of our audience. So this is an epidural hematoma. And there are some specific criteria about when to operate, if the thickness is more than 15 millimeters, if there's more than 5 millimeters of midline sieve, or if the volume is more than 30 cc's. Usually, it is associated with a skull fracture that caused an injury in one of the arteries, usually the middle meningeal artery, and is associated with the so-called lucid intervals. So the patient might lose consciousness at the time of the accident, regain consciousness, and then as the hematoma continues to build up, then they might become comatose again. And if they are not operated, then the usual outcome is unfortunately death. And it has been well established in the literature, from the 70s that you need to operate really, really fast, that any delay beyond 2 hours is unacceptable for this type of hematomas. We also have the subdural hematomas that they are under the dura in the slit-like potential space, which we call subdural space. And usually this is associated with underlying brain injury. So these patients were usually, became unconscious at the time of the injury, they remain unconscious. And there are also some specific criteria in our guidelines that if the hematoma is more than 1 centimeter thick, if it's causing more than 5 millimeters of midline shift, or if there's any pupillary abnormalities, then you have to operate on that hematoma. And again, it is well established in the literature from the 80s that you need to operate really, really fast. And they show that if there's a delay of more than 4 hours, then the mortality really increases. So in reality, we aim to operate as soon as possible. But as we can see, if there's a delay more than 4 hours, then the outcomes are really affected. Then we also might operate for multiple contusions. And what we need to be aware about this type of pathology is that they're very likely to blossom, basically increase in size and create mass effect and compress the brain. And again, there's some specific criteria that we use if there is a refractory ICP, if the volume is more than 50 cc's, and some other more specific criteria. So the types of operations that we do in neurosurgery for trauma, there are basically 3. One is the craniotomy, where you can see here that there was a prior opening to the skull, the hematoma was evacuated, and the bone was replaced with some plates and screws. So there's the craniotomy. Then we might open, another option is to open a small hole and insert a catheter. This is an external ventricular drain that allows both the measurement of ICP, but also the drainage of CSF if we need to do that to control the ICP. And then we also have the decompressive craniectomy, where we open the skull, we remove the hematoma, control the bleeding, but we do not replace the skull to allow for the brain to expand, as you can see here, and that can control the ICP. But by the way, this craniectomy is not really perfect. I will probably have gone a little bit further back in this posterior margin, but it will be still sufficient for this patient. So when we're managing the TBI patients, we follow religiously this publication by the American College of Surgeons. And it is based on evidence, but it's also based on the experience and the expert opinions of many people who are really experienced in treating neurotrauma. Some key points for our publication is that we use the Glasgow Coma Scale to evaluate these patients, and it is important to write each component. So we don't use just the sum, GCS 14, 15, 13. I mean, we use that, but we also need to specify each component, the eye response, verbal response, motor response. That makes it easier for the next provider that will follow up to see if there was any change in neurological exam. Also, this publication specifies some instructions for the emergency medical services that they should bring to a trauma center any patient with TBI and GCS less than 14, or any TBI patient with any GCS if they have an additional extracranial injury of specific severity grade and above the AS above 3. That document also specifies that we should be monitoring the ICP in patients who are in coma with GCS basically less than 8, and they have some kind of brain damage of the CT. And EVT is the preferred method because it also allows for the drainage of CSF, and that's a very, very effective method to control the increased ICP. Also, we have 3 stages in regards to the management of increased intracranial pressure. First, we start with elevating the head of bed. Actually, this is more like, it's also like a prevention measure to prevent increased ICP. We sedate, provide pain control to the patient, and if there is an EVT in place, we drain CSF to control the elevated ICP. If these measures fail, then we proceed with hyperosmolar therapy, either mannitol or hypertonic saline. There's a lot of discussion which is better. Basically, if you're dealing with a patient, actually, I won't go into in details because it's a very long discussion. You can also try decreasing the PaCO2, and you can also do a trial of paralysis. And if there is a response to the ICP, you can paralyze the patient, and this can also have an effect on reducing the ICP. If these measures fail, then we proceed with the most invasive options. Decompressive craniectomy is the number one option, but in some selected cases, we might proceed with a barbiturate or propofol coma, or in some even more selected cases, we might try hypothermia to see if it has any effect on the ICP. Also, this document specifies that we should start early enteral nutrition. If we think that the patient won't get extubated within the first week, then we should proceed with early tracheostomy. We should avoid laparoscopic or any operation under regional anesthesia because this can increase the ICP. If there is a stable CT, we should start Lovenox within 3 days. And another important point is that if we're dealing with a severe TBI patient, we should, in most cases, we should try at least 72 hours of intensive care, aggressive therapy before we proceed with the goals of care, because it's very, very easy to be misguided by the findings and believe that this patient has zero chance to survive. But there have been surprises, positive surprises, that patient survived and had a meaningful outcome. And in general, unless we see something definitive on the CT scan, we should try to aim for 72 hours of intensive therapy before any goals of care discussion. These are some physiological parameters that we try to aim for. Basically, we want good oxygenation, good systolic blood pressure to maintain cerebral perfusion. We want the ICP less than 20-25. The sodium needs to be within normal levels, and the coagulation functions will be optimized. So this is a simplified, let's say, image of how we treat TBI. So we aim for resuscitation and maintenance of normal physiology. We are always aware about the potential for an unstable fracture, so we maintain spine precautions. We aim for an emergent brain decompression and control of the intracranial bleeding. And then we prevent and treat if they present the secondary injury to the brain, like such as edema, seizures, and etc. And rehabilitation is a very, very important component of the overall care. So what we need to remember is like almost everything in neurosurgery, even like a small omission, a small mistake can have a devastating and catastrophic outcome. So even like a short period, like a few minutes of increased ICP or a few minutes of hypotension can lead to irreversible injury to the brain from ischemia, or if we're dealing with an unstable fracture, a wrong movement can cause irreversible paralysis. So attention to detail is paramount for the treatment of these patients. So what is the national authority that, let's say, monitors the treatment of the trauma patients? So American College of Surgeons has taken a leading role in that aspect, and they have some specific aims on how to improve the care for the injured patient. And the two main instruments that they use is the verification of the trauma centers. So each trauma center is being reviewed every 3 years by the American College of Surgeons to make sure that they meet all the requirements of the ACS. And also the performance of each trauma center is actively monitored by the ACS, which provides feedback to each trauma center on how they can improve their performance. And this is risk adjusted, and we'll see some examples of this evaluation for Morningside. So this is the document that basically defines what a trauma center should have in place. So what are the key components? So a trauma center, basically level 1 and level 2, should be ready at any time to treat a severely injured patient. They have the ability to provide rapid emergency department evaluation, availability of blood. There is a trauma surgeon in-house and ready to respond to any trauma case in the ED. They have advanced radiological capabilities, and they are able to perform PAN scan immediately on trauma patients. And neurosurgery, orthopedic surgery, and some other key surgical specialties are also readily available. A trauma center usually also has a surgical ICU, and they have rehabilitation care in-house, basically in the form of PT, OT, access to rehabilitation doctors. And they also have trauma prevention, trauma research programs. They maintain the trauma registry, and probably the most important factor is that they have a performance evaluation system in place. So the trauma centers, they are divided in level 1 to level 4. In terms of the care that they provide, level 1 and level 2 are pretty much identical. And for us, for neurosurgery, there's no difference between a level 1 and level 2. The requirements are basically the same. And neurosurgeon needs to respond within 30 minutes. There needs to be 2 neurosurgeons on call, 1 primary and 1 backup. The main difference for that will make a trauma center being level 1 is that they need to have a specific number of admissions, and they need to have some additional requirements that we already have that over at Morningside. So a key concept is the activation. So we have the full activation, which has a different name in different trauma centers. Over at Morningside, we call that trauma code. Over at Elmhurst, they call that red trauma. So we have the full activation, and there are some specific criteria. For Morningside, these are our criteria. So we have the trauma code, which is like the highest level of trauma activation. And we also have the trauma alert for trauma patients that do not require the mobilization of all trauma resources of the hospital. And in regards to the performance improvement, as we said, there is a performance improvement system in place, and it continuously measures, evaluates, and improves care. And the key thing of the performance improvement program is that we're trying to find opportunities for improvement. So this is not about punishing people. It's more about learning from our mistakes and try to become better. And as you'll expect, there are some barriers in that process. So we need to be aware of what will prevent such a system to be effective. These are usually confidential conversations, and the goal again should be on how we can become better. I think an interesting classification of the trauma centers is by Jeffrey Young, who is an experienced trauma center from Virginia, who has reviewed many trauma centers. So he believes that actually the best category is the trauma centers that they provide good care, but they believe that they provide suboptimal. The reason is that such a trauma center will actively try to become even better. Then another category is that they provide good care, and they believe that they provide good care. The problem with that is that people might not try to become better. So there's more potential for improvement in type A than in type B. Then we have cases where they provide suboptimal care, and they know that they do that. So the good thing about that is, even though they know about it, they should be trying to become better. And the worst category is that trauma centers that they provide suboptimal care, but they believe that they provide good. So this trauma center will not try to get better. So that's the worst category. So in Manhattan, there are 4 trauma centers, 2 level 1, 2 level 2. And somebody might say, oh, why are there so many? There's a rule of thumb that a trauma centers will cover approximately 1 million population. And Manhattan has 1.6 million. So why are there so many trauma centers? Actually, Manhattan should be considered more like a 4 million people city, because there are so many people who commute here to work or to visit the city. So there's definitely like a role for trauma centers. And now let's go to Mount Sinai Morningside, which is located in the Morningside Heights, which a location that has been considered as the academic acropolis of the city, given that there are many higher education institutions. It carries the history of the St. Luke's Hospital with many innovations, including one of the first publications for HIV, and is located in again, Morningside. So a few things about the statistics for Morningside. So most admissions go to trauma. So even if a patient has, let's say, an isolated brain injury, that patient will first be admitted to the trauma service for 24 hours, and then will be transferred to neurosurgery. This is an agreement we have in place. It's actually, I believe it's very, very convenient, because trauma will take care of all the systemic issues. And then when the patient gets transferred to us, we only have to worry about the TBI, and we don't have to worry about things that we're not experts on. And in regards to the admissions, we can see that in 2019, we met the goal for to become a level 1 trauma center. In 2020, we came very, very close, and it's a very, very good performance if we take into account that it was a COVID year and many things changed. And we have very few transfers out. This is a quality metric that is actively being measured. The pediatric transfers out are justifiable because we're not a pediatric trauma center, but any adult patient who was transferred out, these cases get reviewed about what was the reason for that. and whether it was justified or not. And as we can see over here, a significant proportion of our patients are actually geriatric patients, and that seems to be the case in many other urban trauma centers. In terms of the mechanism of injury, falls are by far the most common cause of trauma that we see. And thankfully, we don't see a lot of trauma, of violence-related trauma. And these are some more neurosurgery-specific metrics. These are the transfers that they come to our hospital because neurosurgery is there, the neurotrauma transfers, Beth Israel, Queens, and Brooklyn. We collaborate very closely with the emergency departments of these hospitals, and these transfers are coordinated by NIMAT, and we really appreciate their help, and I'll say a few more things about NIMAT later. And we also keep track of some quality measures for neurotrauma. So as we discussed, any patient with GCS less than 8 should get an ICP monitor. So we measure that compliance, and that percentage is not because we're negligent, but there's usually a reason why we didn't place, and we want to make sure that in our notes this reason is documented, so that there is no doubt about the quality of our work. And the same applies for initiating a VTE prophylaxis. There's usually a reason why we didn't initiate VTE prophylaxis in these patients. They might have low platelet count, unstable CT, or there's always a reason. And we actively monitor these cases to make sure that there was no quality issue. Now let's see how we're doing, how is our performance. So again, this is the risk-adjusted mortality based on the data that are being collected by a dedicated person, by a trauma registrar that the trauma team has. And these are reported to the American College of Surgeons, and these data are getting audited by the ACS. So our performance is actually very, very good. The odds ratio for a patient with severe TBI to die in a hospital is almost half the national average. And this is a performance that has been, it is not just a snapshot. It seems to be like a pattern that we've been able to really lower this mortality. We have always been doing really, I mean, around the average, but all the efforts that we have done the last few years seems to be, to lead to an effect. Another quality measure that we keep track of is any major hospital events like acute kidney injury, pneumonia, take back to the OR, and we're also performing very well in severe TBI. I mean, the hospital is performing very well overall, but in severe TBI, the performance is really, really good. And this is also something that we see a pattern, not as convincing as with the mortality, but there is a trend there that is getting really low. So we're 5 attendings that we take call, and Durkatan is our site chair who constantly supervises us and rounds in person. We review the cases in conferences, and we're fortunate to have him available 24/7 if there's a complex case that we need his guidance or we need help with the OR. We really appreciate that. And as we said, there is a primary neurosurgeon on call, there's a backup person, and we need to be able to respond within 30 minutes. We closely collaborate with NIMAT, both in regards to the transfers, but also in rounding daily on the ICU patients. And we use this robot, which can be the NIMAT provider can move it remotely and can see and hear what the exam is. So that this has been very, very helpful, and we really appreciate the NIMAT input. It was something that was missing from Morningside. And we're very thankful that we have access to the expertise of our neurocritical care team. And we very closely collaborate with the emergency department. Dr. Wedderburn is our trauma program director, which is a very powerful position at trauma center. And we have a very an amazing collaboration with him. And we also work very closely with the rehab team. And we're fortunate to have in our system a model system for TBI and the model system for spinal cord injury. So these are very competitive classifications for our rehabilitation department, and we're very fortunate to have access to their expertise. And the last slide is probably the most important, is the in-house team that make these great results happen. We have 7 full-time APPs. Adoni is our chief, Megan, Alexandra, Lauren, Daniel, Rachel, and Kadian. Our full-time APPs. They're doing a great job, and in trauma, you need to there are sometimes that they're very, very intense, and you need to be very fast and very effective and efficient with your decisions and your actions. And this thing is definitely very, very competent. And we have per diem and Mount Sinai West APPs that they're helping us whenever we need them, and we really appreciate that. And this year we started having PRFs. We had George and Jack rotate with us, doing both SIFs and clinical work, but also doing clinical research that hopefully we'll be able to present to you soon. So I think we're good on time.
Congratulations. Beautiful talk. Very interesting work. High quality work. One question that I have for you, Con, is with a big hospital system like we have now with expertise in various locations, what percentage of the cases that are transferred do you think could have been managed at another hospital or benefit from the transfer and the care, the coordinated care that you give there? I know that sometimes we transfer someone based on a diagnosis, such as a subdural, but not a severity. And so do you have some way of understanding, what sort of threshold in severity is needed to really require the trauma center as opposed to the different diagnoses?
Yes.
The question is clear.
Yeah. So most of our transfers are from hospitals that they don't have neurosurgery or even neurology in-house. For example, Mount Sinai Brooklyn, Mount Sinai Queens. So, in theory, some of these transfers could have stayed there, but having a patient with subdural hematoma being managed in a general medicine service, when there is the option and there's access to a neurosurgery service that they're able to intervene immediately if there's any deterioration, is probably not optimal. And in the past, whenever we try to keep these patients at the referring hospitals, the physicians over there definitely felt very, very uncomfortable with managing these patients, and there was a lot of pressure in making the transfer happen.
Do I understand that about 15% of the cases are neuro? You had about 1,100 total and about 150 neuro?
Correct.
So it's about 15-20% on neuro, and then the others are not neuro.
Yeah, so there were approximately 15% of our trauma admissions are transfers for neurosurgery. The other admissions are patients who were admitted to the emergency department at Morningside or were transfers for general trauma from other hospitals. So these neurotrauma transfers, it's a small component, but I think it's an important component because also for becoming a level 1 trauma center, we see that we're very close to that threshold that the ACF has placed. So these transfers actually are helping us in meeting that requirement. And I think that the current setting is very good for the referring hospital because they don't have to worry about treating a pathology that they're not familiar with. And I think that it probably offloads some other neurosurgery services in our system, like Mount Sinai West or Mount Sinai Hospital, for having to deal with patients who they might have intracranial pathology, but very often they are geriatric patients with many other comorbidities. And having like a patient with many comorbidities in our service, it takes too much of our time that could be dedicated for patients with predominant neurosurgery pathologies.
Great. Thank you so much.
Great talk, Konstantinos. I think it is a great example, and the data you showed really drives home the point that, with a dedicated trauma service and dedicated neurosurgeons with specialty in trauma, that the outcomes really improve in particular.
It's no small feat to have a neurosurgeon available within 30 minutes and a backup neurosurgeon.